Welcome to the Metabolic Classroom, where we explore the science of metabolism and health. I'm Benjamin Bikman, a biomedical scientist and professor of cell biology. Thanks for joining me today for the lecture. Today's lecture topic is a popular one, I suspect, and that is hormone replacement therapy, commonly known as HRT. Specifically, we're going to discuss HRT in women, where it becomes more relevant because of the unique endocrine or hormone changes that a woman experiences. We'll discuss the profound metabolic changes that occur during menopause, including HRT's role in counteracting some of these effects, and also how some of the concerns with regards to cancer or blood clots are, well, we'll put them in perspective, and how perhaps in the past they've been a little misunderstood, and with some new light comes new insight. We'll also explore how estrogens, especially estradiol, impact fat metabolism, inflammation, of course, insulin resistance and insulin sensitivity. These are topics that are, of course, not only fascinating scientifically, but also very practical for managing metabolic health. Now, as we get started, let's discuss and take a moment to have a little bit of a primer or a refresher on what estrogens are. Very often you will hear the word estrogen used as though it describes a single hormone, but that is not accurate. Instead, we should, if we're going to say the word estrogen, put it into a plural form, estrogens. That's more precise because estrogens refers more accurately to a family of hormones. And there are three of them in particular. Typically, if you hear someone invoking the word estrogen, they're actually talking about the main of the most active of the estrogens, namely estradiol, sometimes known as E2. Estradiol is the most potent and biologically active form of the estrogens, and it dominates during a woman's reproductive years. Another one of the estrogens is estrone, or E1. It becomes a little more prevalent after menopause, but is a weaker overall estrogen. And then lastly, there's estriol, or E3. It's the weakest of all of them, but it actually is a little more abundant and has more of a role during pregnancy. Now, pregnancy is not the topic here, so we won't revisit that one. Now, nevertheless, with all of these estrogens in mind, they act on nearly every single cell of the body, from brains to bones, from fat cells to blood vessels. They regulate reproductive health, fat metabolism, glucose regulation, inflammation, and all of the health consequences that come from those things, like where we and how we store fat, type 2 diabetes, heart disease, and all of the above. Now, why is hormone replacement therapy even a topic? Why is that something that is discussed and addressed? Well, of course, that's because of menopause. Menopause is a unique event in women. With some people will talk about a male menopause because of the change in sex hormones in men, but that isn't really to be compared. The difference is so much more profound in women, and it has everything to do with the ovaries. So typically, somewhere between the ages of 45 and 55, that's quite a range, I know, that will be the end of the ovaries' job in reproduction. As the ovaries at this point stop producing eggs, that main hormone estradiol and progesterone, which is not an estrogen, but a closely related cousin, if you will, those levels will plummet. At this point, as the ovaries take a bit of a quiet role now within the endocrinology of the woman, other tissues are forced to pick up the slack. And at this point, most of her sex hormones, most of her estrogens are now coming from two other glands, not her ovaries anymore, but rather her adrenal glands, particularly the adrenal cortex, and then fat cells. Now, just one comment about the adrenal cortex. When I teach my students in endocrinology about adrenal glands, I describe them as something like an orange, where there is a peel and then there's the fleshy part of it. The adrenal, and those are two very different things, two very different parts of one thing that's together. Similarly, on the adrenal glands, we have the adrenal cortex, which is like the peel of the orange, albeit thicker. And then we have the fleshy part of the orange, which is referred to as the adrenal medulla. So all these sex hormones that now become so prominent in its origins, uniquely postmenopausal, that's the adrenal cortex. So nevertheless, just to restate all of that without my distracting tangent, when a woman goes through menopause, the ovaries take a bit of a back seat with regards to estrogen production, and then the adrenal glands and fat cells step up. Yes, the fat cells are a source of sex hormones, at least some of the conversion of these hormones. Okay, now it's in this same state where, of course, a woman may seek to find some substitutes, particularly to replace estradiol's effects, because with the loss of estradiol in particular, that's the main estrogen, that's where these symptoms of menopause come in, including hot flashes, night sweats, and then of course certainly metabolic disturbances. And with these metabolic disturbances, we of course have an increase in various diseases. And I'm going to revisit that point when we start talking about some of the effects of HRT. Now, just for fun, I didn't intend to originally mention hot flashes, but they are so common that I thought it would be, and I've known women who mention them so vociferously that I thought it might be a point of interest here. Hot flashes actually occur because of estradiol's effect at regulating the hypothalamus, the thermostat of the body located deep within the brain. Normally, estradiol will help keep the hypothalamus and that thermostat somewhat stable. But of course, as estradiol levels drop in menopause, the hypothalamus becomes then very sensitive to changes in body temperature. This sensitivity, in turn, will trigger an exaggerated vascular response. And now the body's blood vessels will dilate in order to try to cool off, which will release some heat. It will activate sweat glands. And so the result of this is that the woman will experience that familiar, uncomfortable rush of heat and some sweating. Of course, HRT, insofar as it will replace the estradiol, will help regulate that. Anyway, so now you know, a brief little tangent into one of the more complained about problems or mentioned problems with regards to menopause. Now, I'm not a thermoregulation scientist. I'm a metabolic scientist. So let's transition to focus on the metabolic changes during menopause. Beyond the symptoms like these obvious ones, like hot flashes and night sweats, metabolism is substantially changed during menopause. Now, I have discussed previously in a previous Metabolic Classroom lecture some of the effects of sex hormones. Some of this will be a little redundant, but if you find that you want more information with regards to estrogens and its effects on fat cells, please go through the library of Metabolic Classrooms, and you can find those there. All right, now let's talk about what happens during menopause. And then, of course, all of this becomes relevant when we discuss the effects of HRT. So first of all, insulin sensitivity drops. Estradiol enhances cells' sensitivity to insulin, making the body more insulin sensitive, which of course also has the effect of improving glucose uptake. So it makes it easier for a woman to control her blood glucose levels. But when her estradiol levels start to come down during menopause, insulin sensitivity gets worse, leading not only to a higher insulin level, but also to higher glucose levels, which of course increases the risk of type 2 diabetes. That is a known risk with menopause. This is part of why I say that during menopause, a woman becomes a metabolic mortal, that up until this point, she has been somewhat metabolically immune, and much less likely to have insulin resistance and type 2 diabetes compared to the males in her life. Whereas men have a high risk of insulin resistance and type 2 diabetes, women have a lower risk. Estradiol is part of it. Now, beyond the direct effects of estradiol, and I'm going to revisit some of this when we actually get into the effects of HRT, she has this kind of deeper benefit, if you will, with regards to her metabolic health because of how her sex hormones influence her fat cells. As I've stated emphatically and repeatedly, where and how we store fat matters far more than how much fat we store. This is the reason that women are healthier than men metabolically, despite naturally having a higher body fat level. Before menopause, estradiol supports healthy fat distribution by encouraging fat storage in the hips and buttocks region, or what is technically called the gluteofemoral region, the hips and thighs. But reducing visceral fat, so reducing fat in the abdomen, that's what estradiol is doing. It's shifting the fat so that there's less fat being stored, indeed increasing fat burning on the belly area, but increasing fat storage on the hips and thigh region. Now, of course, not only does the fat get stored in a healthier place because that hips and thigh region is a healthier place to store fat, but the fat cells themselves, particularly those in the abdominal region, are typically smaller because of the effects of estradiol. So with the loss of the estrogens, these fat cells start to get larger. So again, just to state all of this in a little bit of a cleaner way, with the loss of estrogens, a woman will begin to store more fat, not only centrally in her abdominal region, but the fat cells will be larger. And as you recall, with crystal clarity from earlier metabolic classrooms, the larger the fat cell gets, the more insulin resistant it becomes, and the more pro-inflammatory it becomes. And indeed, that's the final point I'll make, is that with menopause and the loss of estrogens, inflammation goes up. Now, this appears to be both an effect of having larger fat cells and a loss of the protective and anti-inflammatory effects of estradiol. So estradiol does elicit an anti-inflammatory profile within the body. No surprise then that during menopause, a woman's levels of her pro-inflammatory cytokines like C-reactive protein, which is the most commonly measured, and others like TNF alpha or the interleukins or the interferons, all of those are going up. I emphasize C-reactive protein, or CRP, just because it is increasingly common when it comes to lab tests. All right, now all of this has just been describing some of the physiology of the endocrinology in women and the metabolic benefits and some of the effects of estradiol. Let's now transition, although we are going to revisit a point of physiology again in a few minutes when I talk about blood clotting. That might seem like a little out of left field, but I'll put it in context at the time. But let's transition into talking about HRT, so hormone replacement therapy itself. Let's start just by describing the components of common forms or varieties of HRT. The first and foremost being the estrogens. Estrogens, of course. Estrogens are the cornerstone of HRT. And just as there are various estrogens, there are various forms in which a woman can get estrogens. The first one is, of course, the most relevant, being estradiol. This is commonly going to come in a form of a bioidentical estrogen, or basically just a biologically active estradiol, identical to the one that would be produced in the woman's body. This is commonly taken into the body either transdermally, like a cream, or oral. Now, there are some consequences to this that we're going to talk about later. They're not equal in their health outcomes. But again, it can be consumed both through absorption through the skin or orally in like a pill form. There are also conjugated equine estrogens. So these are estrogens that are actually coming from a horse. They're not identical to the human, but similar enough to have an action. And then you can also get estrone, or E1. That's a weaker one, and it's usually found in combination therapies. And then there's even lastly synthetic estradiol, which is synthetically produced. It's not coming from a horse. It's not bioidentical, but it's a synthetic form. It's technically ethinyl estradiol. Now, in addition to the estrogens, a woman's body can naturally produce progesterone. And so progesterone is not too uncommonly used in combination with HRT, whether it's progesterone in a bioidentical form or whether it's a synthetic progesterone, usually called progestin. They are included in HRT, especially if a woman has an intact uterus. So the progesterone is generally used in conjunction with some form of the estrogens just to help the uterus maintain good health, good structure. All right, now Why? Why take HRT? What is some of the reasoning that would go into a woman feeling inclined to do this? Well, the reasons are myriad and manifold. There are several, but that's redundant. Let me just list some of those effects. Let's start, of course, with insulin sensitivity. Estradiol helps restore glucose tolerance, so helping her blood glucose levels be in a better range. Also, and likely causing the glucose improvements, she becomes substantially more insulin sensitive. Her fasting insulin levels come down, and all of those surrogate markers, including the triglyceride to HDL ratio, the HOMA score, they all get better as well. I thought you might appreciate, beyond me just stating that and moving on, I actually thought you might appreciate knowing some of the mechanisms, some of the actual changes in cell biology and physiology that explain this. Firstly, estradiol has a direct effect at improving insulin action. I've alluded multiple times in the past to insulin binding its receptor on a cell and then a series of events occurring within the cell. That's commonly called the insulin signaling cascade or the insulin pathway. And there are a few critical junctures in that pathway, one being the PI3 kinase slash AKT pathway. Well, estradiol activates that. It helps that work a little better. Thus, estradiol has this direct effect at improving the fidelity of the signal within the cell. Also, in the past, you've heard me talk about ceramides, how ceramides are the main intracellular cause of insulin resistance, that as much as that PI3 kinase AKT pathway is a necessary juncture within the insulin signaling cascade, ceramides will block that signal. So in order to improve insulin sensitivity, one approach would be to reduce the levels of ceramides within a cell. Now, this is not the same as ceramides in your shampoo or soaps or creams or whatever. This is a separate thing. So these ceramides, when they accumulate in a cell, can directly antagonize the insulin signal. Estradiol activates an enzyme called ceramidase. In that term, perhaps you hear the word ceramide. So this is an enzyme that breaks down ceramides. If you break down ceramides, you improve insulin sensitivity. Estradiol activates that enzyme. Another mechanism is that estradiol will tell the liver to not make new glucose. That term is gluconeogenesis. If you can tell the liver to make less glucose by turning down gluconeogenesis, you can improve glucose levels in the blood, especially in a fasted state. Well, estradiol suppresses gluconeogenesis, so it downregulates some of these critical genes and enzymes involved in gluconeogenesis, making new glucose. Of course, the effect of that is going to be the blood glucose levels have better control. And as I already mentioned, one other mechanism whereby estradiol can improve insulin sensitivity, a benefit that we see with HRT, is that it inhibits inflammation. Inflammation is one of the cardinal causes of insulin resistance. So if you can turn it down, no surprise, things start to get a little better. Also, we come back to the fat cells, which is that HRT will help the woman continue to store fat in the prototypical female areas on the hips and thighs and less so on the belly. That's a healthier method of fat storage, but also the fat cells themselves will generally be smaller. So smaller fat cells, less inflammation, less abdominal and visceral fat. All of these things come together to help explain a generally improved metabolic profile and insulin resistance. Pardon me while I try to mitigate the effects of the setting sun. Okay, let's now transition into some of the historic reasons why women were encouraged to be careful with HRT. The first one I'll mention is blood clots. This one isn't as famous as the cancer one, but oddly enough, there's actually more to say about blood clots than there is cancer, as much as cancer has absolutely dominated these conversations in the past. More and more, we see that those fears were probably, fair to say, misplaced. All right, let's talk about blood clots. First, this is an opportunity for a professor to teach you a little bit of physiology, which of course thrills me. Why are blood clots even relevant here? Let me take a moment to just explain why estrogens affect clotting in the first place, because it is really kind of a fun merging of physiology and function. You see, estrogens increase the production of clotting factors in the liver. There's this process called a coagulation cascade in physiology or biology. It is the process whereby the blood will start to clot together, which of course is absolutely an essential process in order to stop blood loss. Well, this mechanism explaining how estrogen tells the liver to make more of these clotting factors, of course, it's essential for a woman of reproductive age to prevent the excessive blood loss during menstruation. Of course, every month, the woman is experiencing a shedding of the uterine lining. With that comes some blood loss as you are breaking apart some blood vessels. Remarkably, during that same time where she starts to shed her uterine lining, her estrogen levels, the levels of the estrogens, are very high. And so it's a brilliant strategy where it tells her body that, yes, it's time to shed the uterine lining, but also we don't want to lose too much blood. And so the same kind of endocrine state that is allowing that to happen is also the shedding of the uterine lining and the potential bleeding that comes with it. Not to mention pregnancy, of course. Estrogens are very high as a woman comes full term. What perfect timing to have high levels of this hormone that's going to make the blood clot a little more readily. Again, all this brilliant mechanism to ensure that there's not too much blood loss. Okay, now let's bring that all back to HRT. Now that you have that understanding of the physiology in the woman with estradiol and its effects, of course, that same thing happens in men. Men have estrogens. And estrogens influence blood clotting in men too, of course, just to a much, much lower degree. Now, what about the risk of blood clots then? That has been highlighted, and there is evidence, although it's always correlational, to show that there may be some justification for some concern with an elevated risk of clotting. But let's put it in context. One of the problems with these big epidemiological studies that these kinds of data always come from is whether the scientists are reporting relative risk or absolute risk. By that, I mean, if it's relative risk, and this is a whole other topic to talk about the problems with epidemiology and the way data are reported, relative risk can sound quite startling. Absolute risk puts things in perspective again. So just for context, the baseline risk of clotting, of having a blood clot in women that are 50 to 60 or so and beyond, is about 1 per 1,000. A woman who's on even oral HRT, which, as I'm going to describe in a moment, is more relevant with blood clots, that can go up to 2 to 3 cases per 1,000 women. So that's the absolute risk, and it puts it in perspective. It helps you appreciate the fact that that's pretty low. 1 case in 1,000 as opposed to going up to 2 or 3 cases in 1,000. This, again, being what you see in a woman who is on oral HRT, which, as I'll describe in a moment, is the one that has the higher risk. But if you were to state that same thing as a relative risk, you would have this sobering statistic of saying it increases the risk of blood clot by 100 to 200%, 2 to 3 times. And that sounds, of course, much more sobering than simply just stating that it goes up from 1 in 1,000 to 2 or 3 in 1,000. All right, now, the same thing does not apply to transdermal or ointment or, cream estrogen if it's delivered through patches or gels or a spray. And that's because of how it gets into the body. If you're using a patch or a gel, it's getting absorbed through that epithelial layer on the skin, for example, and then it's slowly seeping into the blood, just moving through general circulation now. However, when you take it orally, because of the blood flow from the gut, what you take orally will first go to the liver. And so now in the case of the woman who's taking the oral HRT, she has a lot of estrogens coming right from her gut, right to her liver. And so it's no surprise that the liver may be overproducing these clotting factors, things like fibrinogen or prothrombin or factors 7, 9, or 10. Anyone who's taken some physiology, you're probably shuddering right now as you have me describe this, because maybe you had to memorize the coagulation cascade. But all of these are components of the extrinsic and intrinsic clotting pathways. Again, they're all made from the liver. But in this case, when the liver is getting a little inundated with the estrogens as it's coming from the oral HRT route, it may just result in a higher than normal production of these clotting factors, making it slightly higher than normal, potentially a slightly higher than normal likelihood of clots forming. Now, of course, how the woman takes the HRT matters. With the transdermal estrogens being delivered, through the skin, it bypasses the liver entirely, and thus that risk appears to be totally nullified. All right, let's talk about cancer. This has been the absolute blockbuster headline and concern that you hear clinically. And this is because of a study that was published, mostly because of a paper published in 2002 as part of the Women's Health Initiative. Once again, this massive epidemiological or correlational study leading to the widespread fear. I really want to point out and mention by name Dr. Marty Makary's work on this, because that's how I first learned of the revisiting of the old data. So as much as these data originally created an absolute culture of fear with regards to HRT, Dr. Makary's book called Blind Spots, which I think you'd all appreciate it if this is a topic you want to learn more about, he really highlights how the fear-driven medical decisions about HRT and cancer overshadowed and really went well beyond the actual data. So with these more recent insights, we know that the estrogen heavy estrogens, estradiol mostly, HRT, especially that's those used without women who don't have a uterus, will generally have just estrogens only, HRT, really has no meaningful breast cancer risk, and breast cancer being the main one. All right, now that covers the main concerns that people typically have or that may be discussed as a woman's considering HRT, particularly, again, just to reiterate, blood clots and cancers. I think, again, my scientific opinion, not giving any kind of medical opinion per se, is that those fears are generally overstated. Now I want to talk about some pronounced benefits. In addition to, I already mentioned the benefits of insulin sensitivity. With that, of course, comes a reduction in risk of type 2 diabetes. That's no surprise. The Women's Health Initiative, which I just mentioned, an observational study, indicates that HRT reduces the risk of type 2 diabetes. And you can find these studies in the show notes. But also another paper in 2004 published in Diabetes Care found that HRT users had a 21% lower incidence of type 2 diabetes compared to non-users. That's pretty significant. Now, with all of this talk of metabolism, I can't help but want to focus on a particular manifestation of metabolic problems that appears to affect women more than men, namely Alzheimer's disease. Now, there are not a lot of these chronic diseases that affect women more than men. Men generally die more from pretty much all of these kind of general chronic diseases. Alzheimer's disease is the exception. It really is one that affects women more. So let's talk about it a little bit. Can hormone replacement therapy help reduce the risk of Alzheimer's? Alzheimer's is a devastating neurodegenerative disease, and it's worth exploring. And there is, in fact, growing evidence suggesting that HRT can indeed influence the risk of Alzheimer's, especially if it started during this perimenopausal period. A paper that was published in a very good journal on the topic, the journal is Alzheimer's Research and Therapy, found that women who began HRT early in menopause had better cognitive outcomes and, in fact, larger brain volumes later in life. So the brains stayed a little bigger. Brain atrophy is one of the key manifestations of Alzheimer's disease. But this was particularly true, interestingly, for women that were carrying the ApoE4 gene. You, of course, are familiar with that gene. That is the gene that has been heavily linked to Alzheimer's disease, increasing the risk of Alzheimer's disease. But again, just to state it clearly, on HRT, those women appeared to benefit the most. So collectively, these findings suggest that the estrogens as a part of HRT could, in fact, play a protective role in the brain, particularly when they are reintroduced, when the estrogens are brought back into the body at that right time during that kind of perimenopausal state. Now, for the sake of time, I won't go any further, but just to sum some of this up and add some other comments, HRT relieves some of the uncomfortable symptoms, not necessarily harmful, but uncomfortable, like hot flashes and night sweats, just generally improving quality of life. They also improve metabolic benefits, like where the woman stores fat, her insulin sensitivity, related to that, her risk of type 2 diabetes, her risk of also of heart disease, but also her bones, where HRT and the effects of estradiol helps preserve bone density, reducing the risk of osteoporosis and fractures, another unique pathology of aging, particularly relevant to women. So, in conclusion, there are substantial changes in metabolic health in the woman during menopause, including the ones I just mentioned: insulin sensitivity, fat changes, inflammation, etc., that can increase the risk of numerous cardiometabolic problems. HRT, particularly with estradiol, can help mitigate these effects, improving fat storage and related cardiometabolic outcomes. And while there are concerns about cancer and clots, and they're valid and they ought to be considered, I believe the data suggests that the absolute risks are sufficiently small and, in fact, often overstated. And this is even all the more the case if the woman has really gotten an HRT program that is tailored to her unique needs and her unique time in life. All right. I hope you feel that this lecture has been helpful and that you have learned a great deal on this very important topic. Thanks for joining me today as a part of this lecture in the Metabolic Classroom. Until next time, more knowledge, better health.